Thibaut, vous avez ma présentation? Welcome for that first webinar. It's during the course of obesity. It's an endoscopic and laparoscopic bariatric course. We try to speak this afternoon about gastrojejunal anastomosis, and so we are quite excited to have a very large faculty just in front of us for giving the skillness and answering the question that we can have about some details of that gastrojejunal anastomosis. So we will begin, and the first consideration. Yes. The first technical consideration is the size of the gastric pouch. Gastric pouch is, of course, the size is, of course, very important. It predicts in some publications better weight loss at 1 year, but we know also that additional stapling should be avoided because there is increasing of marginal ulcers very quickly when you enlarge the length of staple line. And I perhaps will ask Jack Himpens about the gastric pouch, the size of the gastric pouch.
I personally don't think that the size is that much important. I think the shape is more important. I believe that the long and narrow pouch usually, does what needs to be done. And talking about marginal ulcers, I'm personally convinced that one of the key factors with marginal ulcer is ischemia. And if you reduce the tension, I believe that there's less of a chance for ischemia.
Okay, Almino?
I think that when we look for the history of bariatric surgery, and I agree partially with Professor Himpens, we could see that in the beginning the size of the pouch were much bigger than we have right now, and one of the improvements of the results are related to the decreasing of the size of the pouch. So I agree that the size is not so important. Must to have a pouch more than 4 to 5 centimeters will compromise the result of the procedure.
Okay. Kelvin Higa, some opinion about that?
Yeah, I would agree with what's been stated. We really have no data to substantiate that the size of the pouch influences long-term weight loss or comorbidity resolution. But I really do think what Jacques Himpens said is the size and orientation of the pouch will make a difference with return to long-term complications, ulceration, reflux, and these sort of things. So in a sense, I believe what Alan Wickrow would say, smaller is better as long as it's not 0. And as far as overall performance, there's been a change with laparoscopic procedures. The old open procedures, it was not unusual to have a 50, 75 ml pouch. Now it's considered a very large pouch for today. It should be between less than 30, more likely 10, 15 mLs.
Okay. Michel Sutter, some...
Well, I think that we have some data in the literature showing that as of 50, 60 cc's, the pouch is too big. Below that, it probably doesn't matter very much. But I do believe that having a small pouch decreases the incidence of marginal ulcers. So that's one of the reasons I try to make a very small pouch in all cases. It may make the anastomosis a little bit more difficult if you have supervised patients and more tension on the sutures.
Okay, some other opinions or questions? Yeah.
Yeah,
Just push on the mic button. The red button at the lower part.
Mic.
Yeah.
The middle one.
The middle one. The
Mic. No,
mic. No, yes,
Mic
below.
over.
This one.
Okay.
Okay.
Thank you. Now, I want to say something about the meaning of the gastric pouch in the functioning of the operation. I don't know if you remember the Miller operation, when he was even giving 3 layers of separate stitches in order to make a very narrow and non-dilatable gastroenterostomy. And the best results we had starting from the use of laparoscopy, and that was not a reinforced non-dilatable gastroenterostomy. So I convinced myself that the new gastric bypass, the present type of gastric bypass, works not because the stomach empties slowly, but because the stomach empties quickly. And so it gives the post-sebal effect, the dumping, the stimulation of the ileal hormones, and so on. This is what my association.
Dr. Buchwald?
I think we can distinguish two functions of the pouch. One is weight loss, and I think the size of the pouch is fairly irrelevant for weight loss. And two, it's to prevent reflux, ulcer, and so on. So it's the complications of making a pouch that dictate the anatomy of the pouch. But in the past, we used to think it had something to do with weight loss. It really doesn't, I don't think. We create a different body metabolism by making a pouch, bypassing the rest of the stomach and duodenum, and that's what causes the weight loss.
Okay. Galvao.
So that's the nature of our job, is to be controversial. So I have just listened that the size of the pouch has nothing to do with the weight loss, but it has to do with weight regain. So if you see the data comes from Harvard and Mayo, there's a study starting with Abu Daye from Harvard that continues in Mayo. He say that he studied patients and see that patients do have the perfect bariatric anatomy, meaning a narrow pouch, no more than 6 centimeters. They have the best weight loss. So if the patient has an enlarged pouch, the weight regain is more, and it will add even more if the pouch is bigger and the stoma is bigger. So that's the new data that we are having, and we are studying, and by endoscopy has been so controversial. Most of those studies are prospective randomized ones. So we have some data that at least for weight regain, the size of the pouch matter. That said, all of the ulcers I encounter, chronic ulcers, most of them are on big pouches. So from the endoscopic perspective, I do believe that the size of the pouch doesn't matter like this for ulcers, but in terms of the shape, as Dr. Hippens mentioned. So a linear vertical pouch, at least in our experiences, is more unlikely to have ulcers than a bold, like with abnormal shape pouch.
Okay, I think
I
it's
think
time.
if I make a further comment, that this, in line with what I said, the volume of the pouch, it's important, in my opinion, because the smaller the pouch, the quicker it empties, and so the weight loss is better. If you enlarge, if the pouch dilates, it empties more slowly, and the weight loss, and then the weight regain is unavoidable.
I'm not a bariatric surgeon, I'm a foregut surgeon, so listening to your comments, would it be a limit to the small size of the pouch, and does it make sense to consider that your limit is the ability of performing an anastomosis? And as soon as you are able to do an anastomosis, the size of the pouch is correct, if I'm following your ideas. Is it something that makes sense?
So,
It is 15 centimeters, 15 centiliters.
yes. So that was the size of the pouch, and after the size of the pouch, of course, we have the gastrojejunostomy. And when we are looking the anastomosis technique in the literature, we see that a small half is doing circular anastomosis, a small half linear one, and some 20% are making hand-sewn anastomosis. Also, it's very important, I think, to have anastomosis regarding the size of the pouch and the size of the anastomosis. We come back afterward to the size. But first, I would have your opinion about the technique. Léon.
I think every bariatric surgeon would probably agree your technique, the one that you're most comfortable with and that you use on a consistent basis, will pretty much be the best possible technique that you can offer. To this date, I'm not aware of any literature that pretty definitively states that any one of these three options can be considered the gold standard.
I agree with you, but when you are beginning bariatric surgery, you have to choose. Before you are confident in a technique, you have to work with that technique, you have to learn, to train, and at least you will be very skilled in the technique. But at the beginning, you have to choose. Right. And what are the arguments to choose one or the other?
One of the, personally, the technique that seems to work best for me would be the hand-sewn technique. And the logic is simply that if there's anything that I don't like about the formation of my anastomosis, it's very easy to take apart and do it again. My concern would be with other techniques that you don't really have that option as easily.
Okay. Almino, what are you doing?
Considering surgeons that are starting with bariatric surgery, and we have to think that these surgeons are not so skilled in suture, I suppose that to use the linear or the circular could be better for these surgeons that are starting in the procedure. But I think the linear suture is easier, is safer. We can have some problems as bleeding that we avoid if we do soon anastomosis. So we have advantages, we have disadvantages regarding any of the anastomosis. Will depend on the training and the preference of the surgeon.
Bruno Diemans?
So we started with the linear one, and you know, we switched to the circular one. You know, we have a bit of standardized the size of the anastomosis. A bit good, not good. I mean, probably a bit more restriction and a bit less dumping. I mean, those things certainly not has been provided completely in literature. And at the end, after 2 years, some publications have shown that size of the anastomosis is going to be quite equal to that of the linear one. If you're certainly not going to do that in 6 centimeters length. The only thing is certainly for redo operations now, I really think it is a bit more safe to do it with the circular staple or hand sew in comparison with the linear one, because you make your anastomosis in the same field of the gastric wall, where if you make it with a linear staple, you're probably going to cross, certainly if you're going to do that underneath the band location, you have to cross different tissue thicknesses of the stomach, where you're just going to choose one size of your stapler height. And also, I think in regarding the vascularization, probably it's going to be better with a hand sewn or a circular staple than with a linear one. That's at least my opinion.
Dr. Chevalier?
I think the opposite is Bruno. With our experience, we've done every kind of. We've done circular stapling, and we had at that time many ulcers, and we thought that it was because there was a crossing between the linear stapling and the circular one. So we stopped doing circular, and we found that hand-sewn is the most challenging, and it's not reproducible because it depends on the skill of the surgeon. So in a university hospital, we had to find something that could be reproducible by everybody, and the linear stapling was found as the ideal for us. But that's true that you must be very, you must think that it's possible to have ischemia if you do two linear stapling too close from each other. So it's a kind of habit anyway.
Okay, Dr. Shah, you have some opinion?
We started with the circular one, then we shifted to the linear, and now we are using always the hands-on, which is, in my opinion, safer from the vascularization point of view, and we didn't have any more bleeding since when we started with the hands-on technique.
Dr. Shah?
Given a choice, probably hands-on would be ideal most, but as we know, there are challenges in suturing. So maybe a combination of linear plus hands-on is probably the best training. It's easier and there is some suturing. Regarding the uniformity of the diameter of the anastomosis, I agree circular gives a uniform diameter to everyone, but that actually does not impact the long-term weight loss. You can size the anastomosis over a bougie with linear as well as circle, as hands-on.
Thank you. Galvao?
I think this data is very interesting that is showing on the screen and it speaks by itself. The question from the chairman was the reasons to choose any of those. So I choose reproducibility and easiness to perform. So the most reproducible by far is the circular stapler. That's always going to be the same. But the most easy to do is the linear suturing there. And what we see is a move when you begin with one of those two, and then if you got on performing this art or you're not doing that enough volume, you will stay on a linear suture. And that's the opinion for the one who not actually doing the surgeries but are training surgeons.
So again, the naive for good surgeons, because we're coming back to the pouch, and the type of pouch apparently doesn't matter too much. So does the type of anastomosis matters? Because you have some circular, you have some linear, you have some manual. So fundamentally, does it lead to different results? Does it impact the results? That's the open question. So probably, if you all agree, that's the one that you do the best. That is the best for you. Is it okay? Yes? Comment?
Let me interject a little bit of history. When we first started doing anastomoses, gastrojejunalostomies, we did them open. And we refined the technique to hand-sewn using 5/0 suture, and we didn't have leaks, and we didn't have many of the problems that seem to have come with the advent of laparoscopic surgery. And I think what laparoscopic surgery has done is try to catch up with the fine technique of open surgery. And it still hasn't done that. I mean, you're still using rope to sew things rather than 5/0 sutures. And the introduction of hand-sewn, and the gentleman is sitting right there, Dr. Higger, who was able to do the hand-sewn laparoscopically just as well as anybody could do it open. And so I think we're just making a circle. We're going back to what we had once perfected.
It's only
we're going to try to perfect it again. And I think just to say everybody do what they do best, no, everybody try to do better.
Okay, we go a little bit further to the stricture rate regarding the technique of anastomosis. And we see that with the circular one, it seems to be very low. The higher rate is with linear stapling, and hand-sewn is in between. Have you some opinion about that? Kelvin?
Well, you know, it's very difficult to look at these studies and compare them because they're not in the same center, they're retrospective, and it's various learning curves. I look at these studies and it means nothing to me, really. What means something to me is what my stricture rate is at a given time and how I can reduce it over a period of time. And it's not going to be through the use of a different stapler or maybe a different suture material and making it larger. The real question is what size should we make that anastomosis to begin with? And does that have any difference in far as outcome? Just like we discussed about the pouch size, does the anastomotic size make any difference long term? So and I can weigh in on the suturing. Obviously, I have a bias with suturing. I think that surgery is a skill. It's not an innate talent you're born with. Nobody is born with surgical skill. And with any skill, it takes practice. And for anything of any value, you can say that it takes about 10,000 hours of practice to be a master at anything. And if you shortchange yourself in your career by doing too quickly to stapling rather than suturing, and I think that you'll never develop that talent or that skill you need to salvage your procedure when it really becomes critical. So part of your career is in performing operations. Part of it is preparation for the worst outcomes possible, because it's our job to take care of patients, how they present.
Yes, Peter, some.
No, I think that the most reproducible method. Sorry. I think a surgeon that does a very reproducible method is the best way to prevent these sort of strictures. And there was early data to show that circular staples actually had a higher stricture rate. It depends on the size of the anvil that you place. And it's easier to place a small anvil in a very narrow point. So there was a temptation to use that smaller one that was technically easier. But since we used the bigger anvil, I think the stricture rate has reduced. I think there's many other things like avoiding big pills and big medications. You know, I grew up with the Demeester era, and we realized very quickly how pills were very toxic to the esophagus and the obstructed stomach. So those are also factors as well as the technical ones.
Okay, that's an introduction of the second important question for the size of the anastomosis, because what is the ideal size of anastomosis and how to calibrate. With the circular one, it's quite easy to do. With the Hansoon, it's a little bit more difficult, and with the linear one, it's more difficult also, because you have not just the length of the staple line, you have also the closure system of your opening that is important. Who wants to give some opinion about that? Almino?
Yes. The data that we have from the literature regarding the gastrojejunostomy is that we have to reach something less than 2 centimeters, and the ideal could be between 12 to 15 millimeters. And I'm looking for the data of the study that we have, and but I imagine that this has a very special series of cases, because this is not the real that we have in the general literature. Because in the general literature, the circular will depend if we are doing with 21 or 25, and besides Bruno used 25, there is a lot of surgeons doing with 21, perceiving to have a very calibrated anastomosis, and this will increase a lot the stricture related to the circular anastomosis. For me, the 4% for linear is too high. This will depend on how calibrated, because besides to decide circular, linear, or Hansoon, this will depend also how calibrated the surgeon decide to do the anastomosis. Our experience depends also regarding the material we used to do. So we have a lot of strictures with unabsorbable sutures, multifilamentar, as Etibond, for instance. If we go to multifilamentar absorbable, will decrease, but the best number we will have with a monofilamentar absorbable suture.
Jacques? The mic, please.
Depends if you think that the bypass is a restrictive procedure or not. And if indeed you look for a rapid gastric emptying from your pouch, the wider your anastomosis, the better. And I think no matter how large you construct your anastomosis or how small you construct it, after a year, when you do an endoscopy, it's always the same. So I don't think it's a critical point.
This is exactly what I think. It doesn't matter. It doesn't matter if the caliber is if small or large, in a few months, all of them will dilate unless they are reinforced. And none of these anastomosis are ever reinforced. So the final destiny of this anastomosis is to become as big as the intestinal lumen is.
So it's a profound change from the previous thoughts about the mechanism of function of the bypass, because I remember having seen some guys calibrating or putting a band around the anastomosis to avoid this dilation. Does it make sense, Bruno?
Yeah, I still think, if you look to the literature, it's a good argument to say that it is more restrictive, the bypass, than we may assume. If you look at the papers in placing a non-adjustable band, now there's a bit consensus that the results in terms of weight loss are going to be better. So anyway, it is just a restrictive part just above the anastomosis. So it has sense. But the thing is that all types of anastomosis, you make either instrumental, either hand-sew, going to dilate a bit. And that's not going to be with a ring. A ring is going to be a fixed diameter. So it is certainly restrictive, and restrictive is a major part of achieving good results after a bypass. Otherwise, those banded bypass would not offer better results than the non-banded. Okay.
The aspect of the endoscopist, because they are reducing the size of the anastomosis when it's too large.
Michel?
Yeah, and I'll get back again to put some pepper on this discussion. One thing we know for sure is that the less than 10 millimeters of diameter, the patients will comply that they are not be able to eat solid food. Less than 5 millimeters, very difficult to drink liquids. That's a point that's very hard to argue on that. After that, everything is arguably. And in a way that, if I may, Professor Scopinato, I have been done, and I'm a witness, anastomosis with 15 years that stays the same. So there's not a single reliable long-term study that those anastomosis will dilate. It's an assumption.
How were they originally?
As an assumption. So I don't have data, not me, not the literature, not probably yourself. No. So it's an assumption from us.
Yeah.
And the other thing is that two kind of bias. There's a positive bias that the patients, they are doing great on their weight loss. We don't see those patients. And I see some of those patients that have huge anastomosis and they keep the weight they lost. But my bias is that the patient that comes to endoscopic revisions, most of them, the majority of them, have an altered initial bariatric anatomy, meaning a bigger pouch and an enlarged anastomosis, as Almino stated, more than 2 centimeters and a half. Some studies measuring the anastomosis says that the patients that we see for revisions, as bigger the anastomosis, more weight regain those patients have. So this is the data that we have, and forgive me to put some pepper and salt on the discussion.
Okay. Yeah, allow me to put more salt on this problem. So, first of all, we're not going to resolve this issue, right? Because obviously we don't know. But there is data. The anastomosis does dilate over time. Lloyd McLean showed this in open bypass when he endoscoped every patient at a year and found that the anastomosis became as large as the small bowel. And Bruno, I have to disagree with you. I think the banded bypass has been shown to give better performance. In fact, Henry Buchwald authored a meta-analysis of all the literature that really showed that the banded bypass had superior long-term weight maintenance than the standard bypass, almost as good as duodenal switch. But I shouldn't have to quote him. He can quote himself.
No, but I just say that. I mean, it's just argument pro that I was just explaining that the band is indeed, that the bypass is a restrictive procedure, and by putting a band on that, you're going to enhance the restrictive part of operation. I was just saying the same.
Oh, I'm sorry.
No.
I thought you said did not show.
I just said it. That is an argument that is certainly restrictive.
Oh, yeah. But, okay, I misheard. So I'm sorry. I'm sorry. I personally don't believe it's restricted. I mean, but we're talking about now a 5 to 10 ml pouch most people are making. And you're restricting off of that. That must mean that your esophagus is becoming a reservoir, and that's not happening. And we do know the emptying is greater, and that we don't know actually the mechanism of action here.
Michel?
Yeah, I think no matter which way you make the anastomosis, some of them are prone to dilate over time, but that probably has more to do with the patient's behavior, how they eat, how fast they eat, how much at a time, rather than the pure surgical technique. I have the same experience as Manuel. I have seen, I do endoscopies myself, and some anastomoses remain very narrow over time and some dilate, and you don't know why. But probably the patients with the dilated ones are the ones who regain more weight.
Another opinion?
Yeah. So just getting back to the salt and the bitter, what I mentioned is that there's no reliable articles. The article you just told us is not reliable, has a lot of flaws on the methodology, and is 1 year. And the other thing is the bias we have with any kind of band, because we gonna only follow the good patients. But the patients that lost their bands, and there's a lot of them that will lose for dislodgement and migration, we don't follow any kind of band.
Okay, I think you have a little bit to move on, and we are moving down for looking for the lengths of the limbs. And is there some special lengths that we'll ask the operators from this morning? Almino?
This is other very controversial issue. I think that we have what we call the regular ROUX-En-Y gastric bypass that we can do using about 80 centimeters, 50 to 80 centimeters of biliopancreatic limb and 1 meter of ROUX limb. In the procedures today, Kelvin said that the only reason to do the ROUX limb with 1 meter and something is that to avoid biliary reflux, and I agree. I suppose that this, I think that we can have consensus here, that all of us will agree about that. We have some support of the literature right now, any new article saying that moving down with the biliopancreatic limb, we can increase the weight loss and the metabolic effect of the procedure. But also we can increase malnutritional problems regarding malabsorption, because we are moving from a restrictive procedure to a malabsorptive procedure. So what we think is we have to look for a adequate balance for each patient we have. But at the same time, I think that it's important to have standards to follow in our day-by-day work.
Okay, Nicolas?
In my opinion, we have 3 different kind of procedure. The purely restrictive ones, and gastric bypass was born as a purely restrictive, and the best version was the Miller version. Then we have an intermediate type of surgery, which I call food limitation surgery, and it's the gastric bypass, which in my opinion works better because the pouch empties quicker and the transit is quicker too. And then we have the malabsorptive surgery. The limit between the border between gastric bypass, if you consider gastric bypass is a BPD, just with very short limb. You simply make longer limb and you have a standard BPD. So it's just what you want to have from the operation. In my experience, we are keeping the alimentary limb in gastric bypass 2 meters. And we have no malabsorption after the first year. So 2 meters are probably still too little.
Dr. Himpens?
Well, there's a tendency to make the biliopancreatic limb longer now. And that's based on a few papers. Amongst them, I remember a paper from Berend from Holland. Now, I don't think there should be more malabsorption if you move down the JJ further away from the angle of trides, because when you think about it, you have a biliary of, say, 150, an elementary of, say, 50 or 60 or 70, about 200, like Nicola was just saying. That's the 200 centimeters that's being bypassed. And it used to be, in the beginning of the laparoscopy, we had biliary limbs of 50 and elementary of about 150. So it was about the same distance. The same distance was bypassed. The only difference is that we have a longer biliary limb, and this probably has to do with concentration of bile acids. But I don't think that's more malabsorptive procedure because the lengths are exactly the same.
Bruno?
I think, I mean, I'm certainly not a fan of the mini gastric bypass for you know, the reasons which are quite well known. But the thing is that, you know, if you see what you know, very good weight loss results that are achieved with that mini gastric bypass a bit unexpectedly, you know, and what is the real cause of that? Is it a very long, narrow tube that they make? Yeah, then we have to really reset a bit the concept of making a micro pouch. No, that's probably not going to be the reason. Probably the reason is going to be anyway that 2 meters of biliopancreatic limb that's going to constrict. So anyway, I think you enhance the malabsorptive effect if you look much more iron depletion, you know, more patients with diarrhea and complaints of malnutrition. So that 2 meters is going to be anyway not an important argument. And if you look to the publication of Turn here from Switzerland, who make a very, very long elementary limb, I think you just keep 75 centimeters otherwise, you see that the results in terms of malnutrition are not so enhanced if you compare that with making your biliopancreatic limb much longer. So that says something that anyway there is a difference in working between the elementary limb and the biliopancreatic limb. I think this is logic. That's my idea.
Yeah, we're coming progressively to the end of this very short web session. I think that it's quite interesting, again, as a naive, just to see that there are a lot of different opinions, different techniques, different concepts. And I think it's interesting to know that apparently the pouch doesn't matter, if I'm right. Bruno, you don't agree?
Yeah, but not so much as we initially thought, I think. You know, Capella was already making a long, narrow pouch. I mean, yielded good result. Okay, most of them, I think, were banded. I mean, now you have the mini gastric bypass concept with a very long one, you know, also quite well restrictive. So the concept of melphobia and other surgeons to make a very micro pouch, it's good to anticipate the marginal ulcer, but it's going to work so much more restrictive, I don't know.
So no answer regarding that, not yet?
No, for me neither, yeah.
No comment?
Second
point that I've seen is that
one more comment on the length, on the limb length. I've said and written so many times that in a gastric bypass, if you keep longer the alimentary limb, you don't go toward malabsorption. If you want to keep to go toward malabsorption, you have to keep longer the biliopancreatic limb.
Yeah, makes sense.
Exactly as you said.
Mm-hmm. So second point that I've seen is that in terms of technique of anastomosis, no agreement. So probably, as we were saying, you do what you can do the best, and that's the best. Third one is the size of the anastomosis. Again, it's based a little bit on the concept of or the mechanism of the bypass. So size, smallest is the best or largest is the best? You, because I know that you are a little bit, yes.
Well, push on the mic, please. Yeah.
It is now 62 years after the first obesity operation was done in 1953.
That's what I wanted to hear.
And look how little data we have. And with, I ask everybody to forgive me, but we're pooling ignorance. And if you pool ignorance, you get a whole big pool of ignorance.
And finally, the length of the limb. Again, I can see that there is no very strict consensus regarding this length. So, Peter, as a physiologist, what would be the option for you? Favor the biliopancreatic limb or work on the alimentary limb?
Well, we wrote a little paper on the duodenal switch patients and found that the longer the biliopancreatic limb, the better the weight loss. So there does seem to be some element in that. However, that comes with its own problems. And I think most of us in doing routine gastric bypasses, we just do it wherever it's convenient. There doesn't seem to be any consensus. I don't even think it's been measured in routine gastric bypasses. I don't know of any study that's measured it. So I think it's more a physical prospect of getting a nice, easy length of mesentery. So most of us go 50 centimeters and divide the bowel there. I don't think it makes any difference.
Maybe we have to move to the other side of the limb because we are talking about biliopancreatic and alimentary. And we are not talking that, I suppose that in Professor Scopinar, we agree with me. The common limb, the most important is the size, the length of the common limb.
So you had some difficulties. So that's for the next time. We will talk about the common channel. Okay, Michel.
Okay, so it's time to finish and to conclude. It was a very nice discussion, and so we see that we know a lot of things, but there are a lot of things that we have to study and to apply after that in the patient. I think one of the best remark also is that not only all the things are surgical, but you have also the behavior of the patient that is very important in all that procedures. So thank you for coming. Thank you for connecting to the internet for the people that come to the website. And we will go further to the video session for this afternoon. Thank you.
Thank you very much. Allez, je te laisse continuer.
Non, moi je m'en vais.
Ça va?
Ah oui, je monte tout d'abord.
Hein?
Je monte tout d'abord. So I will call the chairman for the video session. You have it on the program, I don't know. Vous avez le programme? Dr. Cruz and Dr. Katz, please. You are chairman. Ah, ok. For the next session.